thank you for your introduction. First of all, thank all the organizing committee members of this meeting. Today, I will mention about neurosurgical aspects of acute ischemic stroke and role of neurosurgery in acute ischemic stroke. My outline starts with an introduction, and then I will present case one, and then we will discuss mechanical thrombectomy, and then I will present you my case two, and then we will discuss the compressive hemicraniectomy. Using the American Heart Association's classic definition of stroke, this is a cerebrovascular event resulting in elastic deficits in motor, sensory, speech, or visual function. Approximately 15 million people from all around the world suffer from strokes each year. However, even more importantly, when this definition expanded to include the less classic silent strokes, we define it the significant cognitive decline that occurs as a result of cerebrovascular disease. This number grows to nearly 10 times more common. Despite these numbers, neurosurgeon's role in stroke treatment has historically focused primarily on treatment of hemorrhagic stroke, even though this category comprises only a minority of stroke cases. For instance, approximately 10 years ago, it was pointed out that the joint section of cerebrovascular neurosurgery priorities needed to be rethought when 95% of the presentations at their national meetings were hemorrhagic stroke and only 5% on ischemic stroke. Whereas the disease rates indicating clinical and patient needs are 13% hemorrhagic and 87% ischemic. So there is a big difference that the neurosurgeons focused issues. First of all, case one. She was 72 years old female with hypertension and atherosclerotic heart disease. She had sudden onset right side weakness and dysarthria. She admitted to ER after 4 hours, starting her symptoms. Her Glasgow Coma scale was 13, and in this MRI, you can see partial ischemic interiority supplied by the left MCA, middle cerebral artery. What should we do? Do you have an opinion, or would you like to join for answer? Or I don't know the exact format of this meeting, or we will discuss after the presentation. What do you think about Seren?
Hocam, maybe surgical decompression. I'm not sure. Okay.
Is there anyone who wants to answer this question? What should we do? Okay, medical therapy or mechanical thrombectomy or surgical decompression. So I am focused on surgical treatment. So as you guess, mechanical thrombectomy that I would like to mention about first. Mechanical thrombectomy is type of minimally invasive procedure in which interventional radiologists, neurosurgeons, or neurologists use specialized equipment to remove a clot from a patient's artery. It's an endovascular treatment method. So in this patient, we performed mechanical thrombectomy. But in this slide, you can see the mechanical thrombectomy algorithm. We followed this pathway and performed mechanical thrombectomy. As you can see, a patient admitted to our hospital in 3 hours, and then we administrated to patient IV TPA, and then have a CTA, MRI, and saw left MCA anteriority ischemia, and then had a DSA, digital subtraction angiography, and see in this patient you see M1 occlusion. This is a DSA, and you see the M1 occlusion, and then we performed endovascular mechanical thrombectomy. As you can see, this is a perioperative DSA imaging on coronal plane and the sagittal plane. As you see, there is an occlusion on the M1 segment. And then after the mechanical thrombectomy, when you compare this two top and bottom imagings, you see there is a filling of the M1 segment, and we provide reperfusion. And patient, after the operation, patient followed 1 day in ICU unit, and then we transferred to normal ward and follow the patient 3 days. Excuse me? Okay, no problem. We followed the patient during 3 days at the ward, and then patient discharged with Glasgow Coma scale 15, only with mild aphasia. Now I will present the second case. This woman was 64 years old, and she was heavy smoker with hypertension. She had sudden onset right side weakness and dysarthria, and admitted to emergency room after 10 hours. Her Glasgow Coma scale was 11 with hemiplegia, right hemiplegia, and the patient was transferred to neurosurgical ICU unit. Her Glasgow Coma scale dropped in 6 after 36 hours, and then in this MRI, in this CT scan, the axial CT scan, you can see midline shift to right side, approximately 1 centimeter, and then ischemia anterior supplied by the MCA. This is a total MCA occlusion, and you see the very wide ischemic area. Let me remove this part, and as you see, the infarction area. The important points were the drop of the Glasgow Coma scale and the time. The drop of the Glasgow Coma scale occurred after 36 hours, in spite of the treatments, medical treatments. And what should we do? Continue to medical therapy or consultation to Neurosurgery Department for a possible surgery, decompressive surgery? Is there anyone who wants to answer this question?
Maybe neurosurgery, since medical therapy clearly did not work.
Yes. Let's talk about decompressive hemicraniectomy. Decompressive hemicraniectomy describes the procedure of removing a portion of the skull in order to allow swelling brain tissue to expand outward to relieve compression against the skull in a closed system. You know, the cranium is a closed system, and if there is a mass effect or swelling or any mass compressing the brain, it's very hard to expand due to rigid cranium. Specific hemicraniectomy with durotomy has been shown to relieve elevated increase intracranial pressure in the management of malignant MCA infarction. So the principal goal of the decompressive hemicraniectomy in malignant infarction is to decrease intracranial hypertension, brain compression, and herniation while increasing cerebral perfusion. In this slide, you see the important trials that compare the conservative treatments and decompressive hemicraniectomy methods in the literature. A pooled analysis of Decimel in the first study and Destiny and Hamlet trials demonstrated significant efficiency of decompressive hemicraniectomy compared to medical treatment alone among the patient studies. So in proper patients or in suitable patients, you can perform decompressive hemicraniectomy for life saving. And the neurologists consultate to patient neurosurgery department, and the decompressive hemicraniectomy were performed. As you can see, the continuity of the bone now not exist. So we remove this bone part, open a skull window, and allow the brain expand to this part. So as you can see, there is no midline shift. After 2 days ICU follow-up, patient transferred to ward, neurosurgery ward, and discharged with only aphasia and right side hemiplegia. So thank you for patience.
Thank you very much, Dr.
Is there any
Göktuğ.
question?
Okay, if you do have any questions, you can wait till the end if you think of anything. So we are gonna have Dr. Cierny talk. I hope I'm saying that right. If you want to share your slide or share the screen with your slides.
So Dr. Cierny just emailed me saying that his home internet disconnected. So he's going to the office for a more reliable internet connection, but he should be back by 12:30 or 9:30 p.m. in Turkey time.
Okay.
So we can open the floor up for any questions for Dr. Akyoldaş.
Okay.
Okay. Yeah, sorry.
I think there is no question.
I was gonna say, I'm so sorry. I don't know why the Wi-Fi is bad, but I guess we'll have to wait for 10 minutes. So I sincerely apologize. If you guys can just maybe go grab a snack or something in the next 10 minutes, we'll be back. Oh, there's a question. So why did researchers originally concentrate on hemorrhagic strokes?
First of all, we focused on vascular malformations, for instance, arterio-venous malformations or aneurysms. So the primary treatment of before 10 years before or 20 years before, there is no gamma knife treatment, there is no neurovascular treatment. So the treatment of aneurysms and arteriovenous malformations or cavernous angiomas, we performed only surgery because I mentioned before there is no alternative treatments. So, you know, these pathologies cause hemorrhagic stroke, hematomas, especially hematomas. So we focused on treatment of cause of hemorrhagic strokes. So we lost our focus, lost our concentration on ischemic stroke. because it is very hard to open the vessels or arteries, especially small arteries. So it's very impossible. It is very impossible to remove an MCA occlusion, opening, make an incision MCA and removing the clot or removing the atherosclerotic plate. So we focused on the cause of the hemorrhagic stroke. Hemorrhagic stroke etiology.
There is another question, I think, in the chat.
Yes. I saw.
It says,
yes, the primarily neurologists treat the stroke, but in when branching, for instance, alternative treatments, surgery, endovascular treatments, or administrating of TPA, some specialties, some disciplines get responsibility. For instance, in our hospital, not in our hospital, in the world, neurologists, neurosurgeons, or intervention radiologists perform endovascular treatment. But in our hospital, only interventional radiologists perform endovascular treatment and mechanical thrombectomy. It depends on your special field, your education, and your agreement with any other departments. So in our hospital, only intervention radiologists perform endovascular treatments. But in Turkey, in some hospitals, neurologists perform digital subtraction of angiography and perform mechanical thrombectomy, or in many departments in the world, hybrid surgeons. There are lots of hybrid surgeons that perform open surgery and perform endovascular treatment. It depends on hospitals, agreements, education, and experience.
another question came.
Yes.
Let me just read it before you answer. Stroke requires a quick management since time is limited to save the patient without any neurologic dysfunction. What is your biggest obstacle in emergency action?
Yes, you're right. Stroke needs quick actions to treat or for treatments.
We have another question. You originally mentioned that the hemorrhagic strokes constitute 17% of clinical admissions. However, aren't hemorrhagic strokes more deadly and common in comparison to ischemic strokes? Why do they make up a lower percentage?
Okay. First of all, you said that time is limited when you see a stroke patient with stroke. What is the obstacle in emergency action? for neurosurgeons, the first department that meet the stroke patients, neurologists. So it is very important that the neurologist action and management. So lots of neurologists are very experienced in stroke treatment. So they know what will they do and when. So, but it is very, if you don't in a cooperation with neurologists, this could be very helpful condition. So if you lose your cooperation, this could be the main obstacle in emergency section. And another question. You already mentioned that. Yeah. Okay. In the first slide or second slide, let me show you. The hemorrhagic stroke constitutes 70%, 17%. However, as you can see, if you add the silent strokes, approximately 150 million people suffer from stroke in the world. So the hemorrhagic stroke yes, you are right, the hemorrhagic stroke is more deadly, but ischemic stroke is more common. Yes, it's a very good question.
We have another question. What age would you consider a cutoff for surgical decompression?
In a meta-analysis that was published in approximately 2016, they revealed that in subgroup analysis, the impact of decompressive recurrent on mortality was similar across age, under 60 or over 60, and timing of surgery, and there is no difference between. But all the studies, as you can see, included patient under most of the studies included under 60 years. There are very few studies that publish their results of patients over 60. So there is no sufficient data about this, but we evaluate patient with his age, clinical condition, his neurological examination, presentation, and neurological imaging. So you should act up to patient all these factors. But the literature recommends literature's cutoff age is 65.
There's another question. Thank you for joining.
Yes, I saw this question. I am not a neurologist, so I don't face stroke patients in the first line. However, I know that there is a very huge data about stroke in Turkey, and our neurologists, I think, follow the American guidelines. So I think in my opinion, there is no big differences between the approaches in Turkey and US.
Okay, so we have Dr. Cierny finally came. I'm so sorry if I'm saying your name wrong. But I'll just introduce him really quick. Also, if you want to share your slides through the call, that would be great. So just a little introduction about him. He graduated from Masarykova University, and in 2015, he completed his neurology residency at Brno University and at Medical College of Wisconsin. And after working on vascular neurology at Cleveland Clinic, he is currently a clinical assistant professor at Medical College of Wisconsin. Oh, I think you might, okay.
Thank you for the introduction. Good afternoon and evening to Turkey. And can everybody see my screen?
Yes.
Yes.
Is it a full screen now?
Yes.
Perfect. Excellent. So yeah, I'm very thankful to Dr. Akyoldaş to do this talk on acute stroke management, because now we can resume with what we do, or what I do as a stroke neurologist when I see these patients after the acute stroke management. And the acute stroke management is very exciting, and it's the I think the area where we can help the patient the most. But also very significant things that we can do after a patient suffers stroke. So I have no disclosures. Majority of the information I will present here is from the recent guidelines by the AHA, American Heart Association. I basically followed them. So if you want to dive deeper into it, I strongly encourage to read the original paper. And the motivation that I have is that 80% of ischemic strokes are potentially preventable, meaning we can identify their cause, and they could have been prevented if we intervened enough upstream. So I'm going to talk about secondary stroke prevention. First, about what we do universally for anybody who suffers a stroke, lifestyle intervention and pharmacotherapy, and then we'll talk more about causes of ischemic stroke, and then we'll address what do we do for treatment for secondary stroke prevention, meaning what do we do to patients to reduce their risk of a subsequent stroke. I'll be talking only about ischemic stroke and hemorrhagic stroke and subarachnoid hemorrhage, although is the focus of much of neurosurgical acute management, especially the subarachnoid stroke is out of scope for this talk. So anybody who suffers a stroke, what they can do without medications to reduce their risk. So, well, let's start with a case, and this is a case of adult American suffered an ischemic stroke, and he got TPA and thrombectomy, as Dr. Akyoldaş showed, with good improvement. So now he's back functional. And just without knowing anything about this patient, what the risk factor is responsible for the greatest proportion of stroke in the US, and what are the top 4 known risk factors for ischemic stroke in the US. So even without knowing anything about the patient, if you walk into a patient's room, or if you hear the story, what should come up in your mind? And so there's epidemiological data that uses prevalence of a disease and how strongly it is associated with subsequent stroke. And those two together can give you an estimate of population attributed fraction, meaning a fraction of the disease that can be attributed to a particular risk factor. And these are the data shown for blacks on the left and whites on the right. We can see that hypertension is the single most important contributor to ischemic stroke, and about half of strokes in African Americans can be attributed to hypertension. The other risk factors that are dominant are smoking, obesity, and diabetes. This is the slide is for young patients from Baltimore from one population-based case control study. We can see again, hypertension dominant, more of diabetes and more of smoking in the younger population plays a role in ischemic stroke. So to answer those questions, hypertension is the single most important one, and then there is 4 other risk factors that we can lump together as a metabolic syndrome as well. So what lifestyle interventions should we do to reduce the risk of recurrent stroke, which on average is about 5% in 90 days, and about 10% in 1 year. So it's not very high, but also it's a significant. We want to avoid that, and when we have the patient in the hospital, we can intervene. So what should we counsel on? So nutrition, there's been a study that looked into a randomized controlled trial. It's called PREDIMED, that looked into Mediterranean diet with high supplemented extra virgin olive oil or nuts. And the diet has been successful in preventing cardiovascular and cerebrovascular events, including ischemic stroke. The reduction is significant by about 30%. Low salt diet reduction to less than 1 gram per day reduces blood pressure, as you can see in the picture from a meta-analysis, and it reduces the risk of recurrent cerebrovascular events by about 20%. Lifestyle, exercise, most of patients unfortunately cannot much participate after stroke. It's because of the age and because of the disability from the stroke. But those that can should be advised to be physically active and do some moderate intensity exercise at least 4 times a week, or vigorous activity twice a week. Exercise classes has been helpful to kind of motivate patients and achieve this limit. But more exercise is always better. Smoking cessation. So smoking causes about 20,000 ischemic stroke deaths annually in the United States. So about 12 to 14% of all stroke deaths can be tied to smoking. And persistent smoking doubles the risk of recurrent stroke. You can see that there is a dose-dependent relationship. So people who are smoking 1 pack or more has actually 4 times the risk of ischemic stroke subsequently. Second-hand smoking also increases the risk with odds ratio of about 1.4. So how successful are patients, are stroke survivors in quitting smoking? And data from the US shows that there is a high geographic variability. People from Kentucky are doing the worst. The Northeast coast is doing better. On average, about 60% of stroke survivors quit smoking, which is less than cancer survivors. And both the percentage and the geographic variability suggest that there is, we could do better. On the right, you can see a graph of predictors of success in quitting smoking. So you can see that younger patients are less likely to quit smoking, and uninsured patients are also less likely to quit smoking. So those are kind of probably easy, low-hanging fruit to reduce the risk of recurrent stroke. So what interventions we can do are proven to increase the quit rate of smoking? Well, intensive counseling. So telling the patients, even though we may feel like the patients are, not really paying attention, well, it increases, counseling them increases their chances of quitting smoking. Nicotine replacement and combined pharmacotherapy and behavioral interventions has best evidence in reduction of the smoking, and there's been no randomized trials in testing any of these interventions with second stroke as a primary outcome. In the US, there is a quit line and some text-based intervention that people can enroll in for free that can help them coach and assist in quitting smoking. Drug abstinence, so alcohol intake, if it's more than 2 drinks per day in male or 1 drink per day in females, is associated with increased risk of recurrent stroke. Of course, any stimulants or intravenous drug use can cause stroke, so should be discontinued. We should counsel those patients. So those are lifestyle intervention. Now, what can we do for pharmacotherapy? So hypertension is an obvious target. The goal for blood pressure is less than 130 of systolic and less than 80 of diastolic. There is some exception to those, especially patients have very narrow intracranial circulation, or if they have ICA stenosis that is severe, but before we intervene on that carotid. Medication options is basically any blood pressure medication is as long as it achieves the goal. For hyperlipidemia, we have goal less than 70 milligrams per deciliter. I apologize for the misspelling there. For anyone who has atherosclerosis, which is great majority of the patients, if there is complete absence of atherosclerosis, then LDL goal of less than 100 is appropriate. High-dose statin reduces the risk of stroke by about 15 to 20%. Ezetimibe can be used or has been used in one of the trials in TST, and PCSK9 inhibitor has been able to reduce the risk of recurrent stroke by about 15%, or reduce the risk of cerebrovascular composite, cardiovascular composites, so it's both heart attacks and strokes in one of the studies. But its use is limited by its cost. Of course, diabetes is an important vascular risk factor that we need to get under control, either with metformin, multidimensional care, or bariatric surgery if it needs to be. Obesity as well is a risk factor for recurrent stroke. It's important to recognize patients who are obese and who have a stroke and have very low threshold to treat them with obstructive sleep apnea, or to refer them to a particular program that can help them lose weight. So now that has been so far talking about generic reduction of ischemic stroke risk. Let's talk about causes of ischemic stroke when I try to and you know how we can understand the individual patient and their stroke better. So about 23% of the strokes are lacuna syndrome due to small vessel disease. Then a large proportion is cardioembolic. About 70% is from large artery atherosclerosis, meaning carotid stenosis. And then there is cryptogenic stroke that we do not identify a cause. And about half of them look embolic, meaning cortical, or distribution that is in the artery. And that's called embolic stroke of unknown source. So what do we do with patients who are admitted to a neurology service after stroke? Well, of course, after the acute management is done, we identify the stroke with imaging, either with, well, first clinically, and stroke can be diagnosed clinically, but we do have imaging, CT or MRI. If it doesn't show the stroke, then especially if you do CT, it's reasonable to repeat it. So we identify the lesion and confirm the diagnosis. Because stroke mimics, of course, like brain tumors or seizures, can exist. EKG is a must. Most of the patients get echocardiogram, and then we of course need to look at the carotids and intracranial circulation as well. So either CTA, MRI, or ultrasound is done. And then if we identify a cause, then we are basically done. If we don't identify a cause, the additional studies that we should consider is long-term heart rhythm monitoring, to looking for AFib, looking into particular genetic syndromes or chronogallopathies. Infectious vasculitis can be a cause of stroke and can be looked into with lumbar puncture. And more kind of detailed tests that are not frequently utilized are echocardiogram that's transesophageal, that can visualize the left atrium better and rule out any cardiac thrombus. And same with cardiac MRI. So what is large vessel and small vessel stroke? This is a table that kind of tries to summarize it. So we have anterior circulation, of course, the internal carotid artery that has a smaller branch, anterior choroidal, anterior cerebral ACA has medial lenticular striates, and also a branch of recurrent artery Hübner that has its perforators that are small vessels. MCA has lateral lenticular striates, which are identified with purple color on the picture. So that's a common location of a small vessel disease, a small vessel stroke. PCA has its cortex, so a kind of end artery, but also has its perforators that involve the thalamus and interpeduncular arteries. Basal artery has its perforators as well as small vessels. So this is how we identify a stroke that's in a location presumed due to small vessel disease. So lacunar stroke, as we can see on this picture, is very frequently periventricular, and it needs to be less than 2 centimeters. It needs to be subcortical, and it's usually associated with small vessel disease, as we can see on the flare picture here on the left. If you see lacunar location of a stroke, most likely it's a stroke due to small vessel disease, but things that can mimic it is intracranial arterial sclerosis, Sickle cell disease can cause intracranial atherosclerosis as well. Vasculitis, infectious with VZV, neurosyphilis, bacterial, fungal meningitis. Other inflammatory vascular disease like genital arteritis, and rarely some syndromes like Fabry disease or CADASIL so genetic causes can cause small vessel strokes. And on the other side, we have the embolic looking stroke that's in the end artery. Usually it's a wedge-shaped cortical infarct, as we can see on the MRI. The causes of embolic stroke can be artery-to-artery embolism, which can be intracranial atherosclerosis, or extracranial atherosclerosis, meaning severe narrowing of one of the carotids. Also can be from dissection. It also can be more proximal, so coming from the heart. Atrial fibrillation, infectious endocarditis, different valve problems, thrombus, cardiomyopathy, or PFO with paradoxical embolism from venous to the arterial system if there is a right to left shunt. Also, hypercoagulable states can cause embolic strokes. Most recently, we've dealt this with COVID, but antiphospholipid syndrome or malignancy are also very well-known causes of embolic strokes. If we fail to identify a particular cause, we can call it ESUS or embolic stroke of unknown source, basically to name it rather than to change any management. But it helps, the ESUS kind of entity helps us to name it and call it a day, or consider enrollment in the trial. Stroke not fitting any arterial territory, we see those as well, and we should, if we see, let's say this bilateral thalamic infarcts, as over here, especially with hyperdensity along the inferior sagittal sinus, we should be thinking about venous thrombosis, and venous thrombosis can cause a stroke as well. MELAS, which is mitochondrial genetic disease that causes energetical failure in the brain, as identified on the picture, can involve multiple arterial territories, and rarely can be a cause of a stroke-like image and stroke-like presentation. And then we should think about variant arterial anatomy if we see, for example, bilateral anterior cerebral artery infarcts, because there can be a common origin of ACA. So now that we talked about the causes, let's see how we approach them and how do we treat them. So clinically, after we identify a cause, how does it help to change the management? This is a case of 64-year-old right-handed male who was smoking and history of hypertension, who presented with left sensory motor hemideficits and dysarthria with an age of 6. His symptoms were noted the day before. CTA was without any significant stenosis. So who can identify the cause of this stroke, and what would be the management, if anybody can contribute? And don't be shy. You need to unmute someone. Yeah.
I don't have a guess, I think.
Huh?
I don't think I have a guess.
You have a guess? Well, I will help. Okay, so if you see this picture, this CT, there's a hint. I included both axial and coronal, and I cut it here. So it's probably going to be somewhere around the line, and you can see this hypodensity. Okay, that can be identified both on the coronal. So is this an embolic stroke, lacunar stroke, or not fitting arterial territory? So just in the sake of time, I'm gonna say that this is a lacunar stroke, which is a small vessel. It's less than 2 centimeters. It's subcortical. And so how do we manage those? And we could use 2 antiplatelets or 1. From this is a graph from the guidelines. So if there is early ischemic stroke within 24 hours, and if the NI short scale is than 3, multiple trials showed benefit of dual antiplatelets for 30 to 90 days, or 21 to 90 days. So usually we do dual antiplatelets if there is mild stroke and if we see it very early within first 24 hours. This patient had large stroke and it was beyond 24 hours, so single antiplatelet would be appropriate. The three trials that show the benefit of dual antiplatelets as compared to single antiplatelets are Chance, Point, and Thales. They have different inclusion criteria, but were similar, and all of them have been large trials with minor stroke. We can see less than age of 3, less than age of 5 in Thales. They also included TIA, a high-risk TIA with high risk of recurrent stroke, and they compared different dual antiplatelets, meaning aspirin and clopidogrel with aspirin only. Thales compared aspirin and ticagrelor with aspirin only. All within 12 or 24 hours. They look at any ischemic stroke or composite outcome of ischemic stroke, MI or death or hemorrhagic stroke as well. Major severe bleeding. We can see that the risk of the ischemic stroke has been always reduced with dual antiplatelets. The number needed to treat is pretty high, from 30 to 77. So it's not a miraculous treatment. It's not thrombectomy, but it's something that is established as superior to single antiplatelet for short term. Next case, 78-year-old female with a history of atrial fibrillation, renal cell carcinoma after nephrectomy, hypolipidemia, and prior miscarriage, expressing with acute expressive aphasia and right-sided weakness. And after normal non-contrast CT, she is given TPA. CT shows left M3 occlusion, and that was too distal for a mechanical thrombectomy. So what is the etiology of this stroke? Is it lacunar, embolic, or doesn't fit any any distribution? Anyone?
It's embolic.
Yeah, correct. And what is the cause of the embolism? Is it artery-to-artery embolism, cardioembolism? Again, don't be shy. Anybody any hints, or you can type it in the chat as well.
My guess is going to be cardioembolic from the AFib.
Correct. Perfect. And so what tests you would like to run, Jennifer, and what is the treatment?
If she hasn't had an echocardiogram in a long time, I do like an echocardiogram just to make sure. I do obviously an EKG. I know she has AFib. Make sure she's on some sort of anticoagulation to treat this. Okay.
Makes sense. Yeah, I would only add that with the history of multiple miscarriages, I think testing for antiphospholipid syndrome would be appropriate as well. So atrial fibrillation is a very strong predictor of ischemic stroke. It's a risk factor that increases the risk about 4 times. It's a disease of the elderly. You can see the graph of the prevalence of ischemic stroke patients with atrial fibrillation according to their age. So other predictors of AFib is PR interval that's longer than 170 milliseconds on EKG, left atrial enlargement on TTE, and if they have high SVT burden on telemetry or history of it. We talked about the echo. The reason for it why would be to also rule out the thrombus and also see if there is valvular AFib, because we treat differently valvular AFib and non-valvular AFib. Valvular AFib means if there is moderate to severe mitral regurgitation. This is a graph from the guidelines. In patients with atrial fibrillation, we just look if there is moderate severe mitral stenosis or mechanical valve or mitral regurgitation, and then we would call it valvular AFib, and we would do warfarin. In non-valvular AFib, oral anticoagulants are better in both stroke risk reduction and bleeding risk as compared to warfarin. If there is a sinus rhythm, then we use just antiplatelets unless there is mechanical valve. And in that, for mechanical valves, we do only warfarin. Other heart conditions, infectious endocarditis, if there is intracranial hemorrhage, we delay the surgery, but otherwise, many times we do early surgery, especially if we feel like the recurrence of the risk of recurrence ischemic events is high. So for infectious endocarditis, cardiothoracic surgery should be involved. 57-year-old female with history of smoking, hypertension, hypolipidemia, heart failure, left atrial artery, present with acute aphasia, and right-sided weakness, and it was 11. The CT and CTA is shown. Just in the sake of time, on the CT, I think there is some sulcal effacement in the left MCA territory. The CT angiogram is surprising because I don't see an M1 segment, middle cerebral artery segment on the left, and I don't see a middle cerebral artery segment on the right neither. But because of the symptoms of acute aphasia, right-sided weakness localizing to the left MC, I think that is symptomatic. We did CT perfusion in this patient, and you can see the blood volume that's basically unaffected on the left on the colored pictures, and you can see the reduction in the transient time, transit time and Tmax, meaning that it takes longer time to for the blood to get there. This tissue is perfusion dependent. This tissue hasn't died yet and is a penumbra that is amenable for thrombectomy. So this is a lateral view of cerebral angiogram where you can see the internal carotid artery, you can see the posterior cerebral artery. And I think this is ophthalmic artery, and what we are completely missing is the middle cerebral artery and anterior cerebral artery. After thrombectomy, the middle cerebral artery is restored. I think the anterior cerebral artery is going to be captured by the contralateral side, and we can see a residual narrowing there. So this is a successful thrombectomy with severe residual MCA or M1 narrowing. So this patient had successful thrombectomy. You can see the MRI down here below. So we saw that the majority of the MCA territory was threatened to be infarcted, and the size of the infarct is remarkably small after the procedure. What is this etiology and what is the treatment of this stroke? And this may be a tough one because it's a less common presentation. The cause is severe intracranial atherosclerosis. The patient has bilateral MCA stenosis. If the stenosis is more than 70%, as was seen in this patient, then we should do dual antiplatelets for 90 days. If the stenosis is mild, meaning 30 to 70%, we should consider dual antiplatelet therapy for 30 days if the stroke is small, based on the Thales trial. Cilostazol sometimes can be added to the dual antiplatelet therapy. What is not helpful, at least initially or as the first line, is intracranial stenting, warfarin, or extracranial intracranial bypass. Workup of this intracranial atherosclerosis can include sickle cell disease and autoimmune vasculopathies. So this patient's presentation is remarkable for this narrowing, for this severe stenosis, and if the patient continues to have hypoperfusion, then the bypass can be considered, but early on as acute stroke management, I would not, it doesn't have the data for it. This is another case. A 55-year-old patient with some vascular risk factors had central vision loss in the left eye, and ophthalmology confirmed central retinal artery occlusion. There's been some concern for narrowing on the left, but it was not on the left internal carotid artery. It was not well visualized on CTA. An angiogram was performed and showed 60% stenosis. Now, how do we manage intracranial carotid stenosis? So if it's symptomatic and it's more than 70%, that endarterectomy or stenting is recommended. If it's 50 to 70% on cerebral angiogram, still intervention can be considered. If it's less than 50%, then medical management only. There's different indications for each of those, and I think I will not. Generally, the stenting has high risk of periprocedural ischemic stroke. The endarterectomy has higher risk of periprocedural MI. So we can risk stratify and pick up which is probably safer. Asymptomatic carotid stenosis should be generally managed medically unless it's critical severe and it's causing flow limitation problems. So to summarize, we should do to summarize the lacunar stroke syndromes, and we should do dual antiplatelet treatment. For intracranial stenosis, we do dual antiplatelet therapy longer. For sickle cell disease, there's chronic blood transfusions that are helpful to reduce risk of recurrent stroke. For vasculitis, we treat the underlying infectious cause. If it's autoimmune, we treat with immunosuppressants such as steroids. Rarely, if there is Fabry disease, agalsidase alpha has some symptoms of headache, but hasn't really shown to reduce risk of ischemic stroke. Embolic strokes, so if it's small, NIH less than 5 is small stroke, small deficit, and dual antiplatelet therapy for the cardioembolism. For cardiac dissection, we can do either 1 antiplatelet, 2, or anticoagulation. For non-valvular AFib, we use oral, new oral anticoagulations. For valvular AFib, warfarin, infectious endocarditis is treated with IV antibiotics and plus or minus surgery. Artificial valve with warfarin, LV thrombus, of course, with warfarin as well. Low EF cardiomyopathy can be either with anticoagulation or antiplatelet. A paradoxical embolism, if there is a large right to left shunt or septal aneurysm and no other cause of stroke identified, and PFO closure can be considered. For antiphospholipid syndrome, we use heparin and warfarin. For COVID, there is a low dose anticoagulation. From malignancy, low molecular weight heparin, but of course, treating the malignancy is important. And then there is a rare deficit synthetase beta synthetase deficiency that can be treated with pyridoxine. In some responders, it may be helpful. But if you look at this overall, if you cannot put it in the one bracket, and if it's a small stroke, always do dual antiplatelets. Dual antiplatelets for 21 to 30 days in small recent stroke. Venous thrombosis, of course, with anticoagulation, and MELAS, there's some weak data for L-arginine, but it's never been shown in a randomized trial to be beneficial in stroke risk reduction. Thank you so much. Any questions? Sorry, I was talking quickly. This is I would say wide topic, but any questions for Dr. Akyoldaş or me?
Well, if there are no other questions, I just want to thank both Dr. Akyoldaş and Dr. Cierny for joining us here today and tonight. And especially thank you to Coach University for bringing so many wonderful students to this talk. But yeah, so if anyone has any questions, feel free to email either respective chapters, and we'd be happy to pass it down to either doctors here. If there's anything else, there's nothing else.
There was a question in the previous talk, and they asked how do you decide which doctor to choose, neurologist or neurosurgeon, when you receive a case? And Dr. Göktuğ Akyoldaş answered it from a neurosurgeon's perspective. Maybe you would like to answer it from a neurologist.
Yeah, from a neurology perspective. Okay, well, I think whoever can treat it faster, who is on call, whoever is closer to the patient who can do it. I don't think there is. There are nurses. So I would say if somebody is candidate for endovascular thrombectomy, to have somebody who's trained in those procedures. And those people here in the US can have different training backgrounds, either from neurosurgery or from radiology or from neurology. So whoever is trained for it should do it. Usually what we have is that there is primary stroke centers that are able to evaluate patients acutely and to offer the TPA. And that can be done by, that's usually involved neurology. And then if the deficit is severe and if large vessel occlusion is identified and the patient is candidate is in the window, then, you know, whoever who has that capacity to do it as soon as possible. And yes, many times it's neurosurgery. Yeah, I think, you know, there is different ways how to build these systems of care. It's just that somebody needs to be on call all the time to pick up the phones. And what we found here is that the neurology is usually returning all stroke pages initially, because most of those are either stroke mimics or TPA candidates or just, you know, smaller strokes. And if it's a large vessel stroke, then when intervention is needed, then we get the proceduralists on board.
Okay, thank you. Are there any other questions? And if not, we would like to have a quick photo before ending the meeting as a memory. Anyone who wants to join in the photo, you can turn on your cameras. Yes. Okay. Okay, I think, thank you everyone. Thank you to both Dr. Akyoldaş and Dr. Cierny for giving us these amazing talks. And thank you to everyone for joining in.
Thank you, everyone. Have a good day and have a good night.
Yes.
See you.
Hope to see you in future events as well.
Thank you. Good night.